technology, and as soon as that is up and running, we'll start. Good morning, colleagues, those who are in the chambers, good morning. Our guests in the chambers also, good morning, and those who are online, good morning to everybody, and our apologies for the couple of minutes. We were dealing with some technological challenges, but it has now been fixed. Once again, thank you for making the time for this meeting, and we will go through presentations. But also before we do that, I'm going to give a moment of silence so that we can reflect. And please, folks, in our moment of silence, can we take the family of the late Minister Provincial into our thoughts? It's one of our stalwarts in South Africa, a former colleague of ours, and our moment starts now. Thank you. Also, colleagues, we know the drill for record purposes. I'm Memory Boyson, and I'm the chairperson of the Standing Committee for Health. And I'm going to give an opportunity to the committee members also to introduce themselves. And I know that some of the committee members are also online, but we will start in the chambers, and then we're going to go online. And after that, I will give over to the officials to introduce themselves. I'll start on my left-hand side. Maybe it's ladies first. For the introductions, colleagues.
Good morning, members. I'm Member Donita Stevens, and I'm a member of this committee.
I'm Thomas Walters, also a member of this committee.
Good morning, everyone. My name is Rachel van Vogel, and I'm a member of this committee.
Thank you, colleagues. Any members online? Member van Beek?
Yes, good morning to you, Chair, and to the committee and to the officials. I'm a member of this committee, and I'm online today. Looking forward to the presentation. Thank you.
Thank you, Member van Beek. I'm coming back to the officials in the chambers. I'll start on my left.
Morning, Chair. My name is Namanda Jamke, Provincial Officer for Health and Social Development.
Thank you. They're busy there. I'll give over to our guests.
Good morning, everybody. My name is Renee Nassen. I'm a child and adolescent psychiatrist. I'm the clinical lead for one of the 3 child and adolescent psychiatry services in the Metro at Lentegeur Hospital. But I play another role as the provincial lead to coordinate and lead transformation in terms of how we deliver child mental health services. Thank you.
Thank you.
Good morning, everyone. I'm Carol Dean. I'm the Director of Specialised Hospitals. It includes the psychiatric hospitals, oral health, and Western Cape Rehab. So the 4 psychiatric hospitals are Lentegeur, Stikland, and Valkenburg, and then it's Alexandra Care Rehab Centre as well. Thank you.
That sounds like a lot of work for the 2 ladies there. Namonde, any apologies that you're aware of?
No, after the registry.
All right. That's a good start. Dr. Nassen, I don't know who's going to start first, but we will give over to you. I think it's Ms. Dean.
So good morning again. Firstly, this is my 3rd time, Honourable Chair and Honourable Members. So I'm very pleased that you have placed mental health on your agenda. We had various presentations in the past, and we thought we'll do it a little differently this time. So I will do a high-level overview, and Dr. Nassen will look at child and adolescents. So just to give you a breakdown of what we'll discuss. Sorry, that's gone too fast. No, it's supposed to be here. This one. Background. This is the one that I took from. Sorry, we're just trying to figure out why the presentation isn't coming up in order.
All right, whilst you ladies are doing that, just for the record, one of our members, Member Van Minnen, we're aware that she's, what is the word in English? She's working remotely and she's out of the country. Apologies are accepted and noted. Is the presentation not flighting?
I think they must present on our flight.
All right.
We had sent it previously, but we were asked to use our own equipment, so we're just making sure we got the correct one.
Nomonde has a plan here. What do you suggest, Nomonde?
Okay, they can continue and present. The members can check on their hard copies, and I will also try to flight it, Chair. Thank you.
All right.
I'm going to share it.
Thank you so much. We're so sorry about that.
No. It's understandable.
I don't see it being flighted. Is it okay? Can I go ahead?
Present from the slides.
Can I?
Now, the members have their.
Oh, they have the copies.
We have hard copies, yes.
Okay. So, okay, we'll just get going, if
Okay.
that's okay.
No
So we've
problem.
given you a background and outline. We'll talk very briefly about our vision and mission, our strategic approach. We'll talk a little bit about how we define mental health. We'll speak to the burden we experience. Okay. We experience just some provincial overview and the services at the different levels. And then we'll talk about how we've prioritized mental health in the province. And then there'll be a focus on infant, child, and adolescent mental health strengthening by Dr. Nassan.
Okay.
Thank you. So just to say, I think no presentation can take place without just pausing to look at our vision, which is access to person-centered quality care. And it's something we take very seriously. As part of our mission, we undertake to provide equitable access to quality health services in partnership with the relevant stakeholders within a balanced and well-managed health system to the people of the Western Cape and beyond. And I stress that because it's something we take very seriously, and you can see it in the work going forward. Our values, and I think we can all relate to this, speaks to innovation, caring, especially in health, competence, accountability, integrity, responsiveness, and respect. And again, sir, it's nothing that we take for granted. So we've got a 2030 healthcare strategy, which is a long-term view, which is person-centered. It speaks to a life course approach, speaks to integrating care and continuity of care. And some of this may sound like words, but hopefully you start seeing it as the presentation progresses. I think the important thing is that Healthcare 2030, we really want to push the whole idea of self-management, that I take care and responsibility for my mental health. Sorry, Secretariat, it seems like your presentation is flighting incorrectly.
Yes.
So just about our common agenda, our department has come up with a process of looking at an agenda that includes doing, the action of our agenda, building and testing tangible solutions and bringing them to scale. And you're going to ask us, how have we done this? And we'll attempt to do some of it later. Being, connecting agenda, building trust and connections across boundaries, within our department, with our partners, WOGA, WOZA. Becoming, that we as a department truly and deeply try and understand the human experience of navigating services, belonging, aligning around a clear and shared intent for the work we do together. And I think that is, sorry, are you looking at the same presentation I'm using? Okay.
Yes, we're following.
Thank you. So I'm on the life course approach because we've confirmed that in health, and probably other departments too, to some extent, but in health, we will see people from preconception right through pregnancy. They have a touch point with health, infancy, childhood, all the life stages, adulthood, into the older adulthood. At all points in the life course, do we have contact with the Department of Health. Just defining mental health, and our one is, defining mental health. We've taken on the World Health Organization's definition. Mental health is defined as a state of well-being for the individual to realize his or her full potential, cope with the normal stresses of life so that he or she can be productive and able to contribute to his or her society and community. And so the mental health is in the center of everything, any community, any family. We all know mental health has taken on a particular role. No more can we say that's not important to us. And that we need an approach that is preventative, we need an approach that responds to illness, and we need a response for recovery. So my next slide speaks to understanding mental health, the continuum. And so for most of us, hopefully we are healthy and we would like to keep as many people healthy. But no matter who we are, we will all have stresses in our lives, be it loss, be it relationships, be it work-related, and then sometimes we become distressed, and that's normal. Then we could move on the continuum, where we have symptoms that are prolonging, that have become more difficult, anxiety, anger, distress, and maybe at some point in our lives, we may want to seek professional help. And then on the other side of the continuum, where you need professional help, where it is quite severe and persistent, and that's where we come into the to Department of Health, where we definitely provide those services. But it's a continuum. I could be in the orange block and move back to the yellow or the green. I could be in the green block and move to the orange. So we're just aware it's not just all mental illness. You start off being mentally well, and there is a continuum. And I think that's important. So we can all put ourselves in position to understand how that is. So we've had a prevalence study. In 2009, it was published by the SASH, South African Stress and Health Survey, and they did a prevalence study, and the Western Cape came up as the highest prevalence for a 12-month period for adults, 39%. Bearing in mind, sir, that this is in 2009. We do need new data. At the time, we couldn't even conceive of these numbers. We now can tell you we feel the stress of these numbers, and there's a suspicion it may have increased. So we thought we'd just give you a visualization of who we're seeing in our services. This doesn't speak to the burden as in prevalence, but who we're seeing. And if I just speak to the yellow part of the circle, that's the percentage proportion of people we're seeing between 18 and 59. And that's 89.5%. Under 18s is the lighter blue one, just over 5%, 5.4%, and that is growing. And you can see it on the light blue graph in the bottom corner on the right-hand side. The other 5%, which is the dark one, is psychogeriatrics for older persons. So even older persons need acute care for psychoses or a combination of things. We have more males generally in our services than females presenting for care in this case, 63% in the adult group, and under 18 we have 51%. For the older persons, we have more females, 55%. That's interesting. The adolescence is growing. That's what I need you to hear. The next one is just another visualization of who we're seeing in our adult acute services. So this is cases where people are so deeply depressed or psychotic that they need care. Bipolar mood disorders or a combination of things. But what we want you to look at is that red band across. That is for substance-induced psychosis. So it's almost substances on its own. It doesn't mean that substances aren't involved in other admissions, like in schizophrenia, where you see the yellow, or the mood disorders with the light blue below. And there's a group that we haven't been able to code, which is the darker blue, so we call it other. But just purely substances, if we could put it that way. We used to see on average 20%. The numbers seem to be projected at a lower percentage. We're very pleased with that, but still high numbers for substances. So we're looking at the under 18s in my next slide. A similar picture, different proportions, a similar picture, higher substances, but we find as they become adults, they move into a more severe diagnosis, and you see the schizophrenia getting larger. So this is a smaller percentage. There's mood and there's other. I just wanted to share the next slide with you, which is the different levels of care. So our Mental Health Care Act has been around. I have shared the details of that in previous presentations. It's been around for almost 20 years now. And at the time, you may have come into a community, but you would hop over all the services and come straight to a psychiatric hospital for your care. In the last 20 years, we very proudly can say there's a footprint for mental health at all levels of care. Of course, we need to work on it, we need to improve it, but if you look at level 1, which is community-based services, there's a footprint for mental health now. Primary health care, there's a footprint and a more convincing footprint there. District hospitals, that was new with the Mental Health Care Act, they're seeing hundreds of patients a month, thousands in a year. Transitional care also including mental health, our regional hospitals and our tertiary. And of course, specialized hospitals I've highlighted in yellow, that's where we are as the psychiatric hospitals. And that interrelationship continuity of care, this is what we talk about. Because before, you'd be admitted to a psychiatric hospital with no linkages to care, even within the same system. And we're trying to change that, but also beyond our department. I just want to acknowledge here, my next slide, so mental health has always started from a very low base in terms of funding, but with putting it on the agenda for 2 years in a row, we got some additional funding. And last year we got close to 80 million and the year before 30 million. And part of it was to strengthen mental health capacity at primary healthcare level, to help some NPOs in the rural area, which really needed some support, to strengthen Dr. Nassen's team for child and adolescents, to open up a few psychogeriatric beds for older persons. We had nothing in the Metro West side, and just to help with some beds as well. So you can see the division of that for 80 million. And we've been very, very grateful. And it also came as a consequence of many discussions at levels like this with our minister, etc. So from a provincial perspective, there was a focus put on mental health in 2022 when our Premier asked our HODs in the province to form a steercom for mental health. Post-COVID, our numbers were increasing significantly. And we have since been meeting Department of Social Development, DCAS, that's Culture, Art and Sport, local government representation and education, of course ourselves, and we have been going with our HOD, and our HOD, Dr. Kluti, chairs the meeting. And we have tried to focus on, we have focused on children and adolescents. We had 2 pilot sites we worked in for a year or so, just learning about what happens in the spaces, one in Witzenberg and one in Gugulethu in a younger area, where we did some mapping, we did some connection building with other departments, trying to get an ecosystem approach going. We're also trying to look at the best evidence in place We're looking at our data. So that work will continue, and our focus will be on WOGA and WOZA, and we will continue to look at the youth as a group, and Dr. Nasser will speak more to it, and our focus will be on primary prevention. So we want to catch our youth before they become so ill that they need a hospital bed. We want to try and capacitate them with a sense of agency around their own mental health, them and their parents and their supports. I thank you and hand over to Dr. Nasser.
Thank you. Over to you, Dr. Nasser.
Honourable members, thank you very much for the opportunity to represent children and adolescents. So just to start with an overview, I thought that maybe to start, a couple of things that you should know about child and adolescent mental health. So the first is, and I'm sure this is not news to you, it's suicide is the #1 cause of death among the youth and young people. Depression is among the top causes of the global burden of disease. But I think it's important for us to recognize before we move on that depression is not the only cause for a child and adolescent suicide. And then the important thing in terms of why we are trying to shift away from a disease model and to intervene early is that 50% of mental disorders start before the age of 14. And then the second, as a strategy, it's important that we take a life course approach and to understand the risk factors from conception, how it affects infants, the parents, and also to recognize the protective factors so that we can have an approach to actually addressing the vicious cycle of what it is that people struggle with in our context. I thought that the next slide, please. The context for children and adolescents is what we speak about when we say ACEs, or adverse childhood experiences, and it forms the bedrock of the cause of mental distress. And so to start with a busy slide, what I'm speaking about here is emotional abuse, the different kinds of physical, emotional neglect, but also how children get managed within the home, the caregiver or parenting practices, and how this fans out to what happens within families, violence, drugs, and the impact of divorce, and so forth. And then, of course, as it fans out into household and extended family stress and distress, like use of substances and alcohol, food insecurity and poverty, and so forth. And in our context, often and unfortunately, it actually extends to community issues where there are communities where there is very little economic opportunity, young people not achieving their educational potential, and unemployment, and of course bullying, which by the way is one of the key causes nowadays of children actually self-harming out of distress and coping at that. And moving forward then, and I'm speaking about the theory of intergenerational adverse childhood experiences, we need to see this as something that can impact not just a child, but impact for a lifetime. So you would have, next slide please, adverse experiences, and it's been shown in research that it impacts both on physical and mental health over a lifetime. And the consequence for this is devastating because it impacts on people's capacity to function economically. It results in low income situations. And so the question is, where can we focus? And of course, this is where we have to take a whole of society approach. This is not something that a small component like child mental health services or psychiatric services or health is going to be able to intervene. But at least that which we can do is to recognize adverse childhood experiences result in severe distress and behavioral problems, which may or may not necessarily result in a mental disorder, but it causes emotional dysregulation, as we call it, and there are opportunities to intervene to alleviate distress and, of course, to intervene in terms of child protection services that need to be responsive. And so, next slide, please. Moving back to the issue of suicide, I thought I should just mention this as one of the most devastating consequences of adverse childhood experiences. The slide that you are looking at the moment is a study that was done in the West Metro area, and it was published in 2018. And there already we were seeing that suicides were increasing. And unfortunately, we also saw a shift from the highest prevalence being in the 14 to 18 group to a younger group of 10 to 14. Now, going to the next slide, unfortunately, we have continued to see a rise, and I'm sorry that you can't see the numbers. This is suicide data for 2022, and we've seen a rise in the 10 to 14 year group of 14 and 15 to 19 of 38. And recently we have been engaging with the Western Cape Education Department to track the numbers, and unfortunately we are seeing a steady increase as we speak. So what has been our approach? Next slide, please. My colleague mentioned the budget allowance to strengthen child mental health services. And with part of the budget, we were allowed to form a dedicated team for a period of time, 5 years, and this was 2.5 years ago, to actually design and implement a strategy to look at child mental health services more holistically. Up to date, child mental health services, or shall I call it child psychiatric services, were really happening only at the top of that triangle that you see there within tertiary specialist services, which is very disease orientated. It's literally intervening where a lot of the harm has been done and the child has already presented with a mental disorder. And we really were trying to reverse that phenomenon. And with that, a team was established to look at what kind of a strategy do we look at in order to strengthen the primary healthcare base, and not just within health, but also within the NPO sector. And so we have a team, and what we prioritized initially was to look at what kind of training and capacitation can we provide for our colleagues at primary health care. We have designed a psychological framework so that we can do that early intervention around helping a distressed child to self-regulate and so forth. And then we also have designed competency frameworks so that our frontline workers feel comfortable to be able to do an initial assessment, a mental health assessment, or any assessment for a child, and to be able to discern what is the actual problem here. And because it might not be that the child has a mental illness, it might be that the child is distressed as a result of adverse childhood experiences and may need child protection services, for example, to intervene. And then we are very proud of our digitizing project, which we have designed a website to make information about child mental health services more accessible to everyone, to see at least which services do exist. And we've also developed some assessment tools, digital assessment tools, so that when a child arrives in an emergency center, that we can improve the assessment done, and particularly the risk assessment, because that is where the potentially suicidal child arrives. And we have done that in partnership with Dr. Moisa Parak, who actually initiated HECTIS. HECTIS stands for Hospital Emergency Tracking and Information System. And we are also very proud of our early years project. We are planning to provide support in birthing sites. In the old days, we called it midwife obstetric units. And so we really want to intervene as early as possible. And then we've had lots of expert engagements and partnerships that we have built. You'll see on the right, that is the reach that we have attempted and does exist. We've made many more partnerships, more relationships, but it is going to take years, and the more we work together, the more success we will have. Our strategic approach has been to align with our provincial project, as my colleague described, and to optimize and strengthen our focus across the mental health continuum rather than to focus just within specialist services. We are trying to be catalytic and innovative, and we also are interested and have built good partnerships, as I mentioned. I won't go into the detail about the journey so far, but we've had a strategy year by year. We are now 2 years into our project, and we hope to achieve the goals that we've set ourselves. And of course, then our aim is to improve the quality and competency, and we want to build these supportive networks, and we want to see the establishment of infant and family-friendly interventions. Just move on to the next and the following slide, please.
Next one.
Next one. Next one.
Yeah, we're having a jumping approach here.
Okay, not to worry. Now, as the colleague mentioned, my colleague, our approach is to deliver services to the wild child, to prevent these adverse things happening, to identify the at-risk child. And that is important in terms of our collaborative work with the Western Cape Education Department, which we are doing. And then, of course, to detect and intervene when the child has presented with a mental health condition. Next slide, please. And that will mean that we will have the approach to address the continuum, where we recognize the reasons for the distress and intervene, and to prevent more children from becoming ill. I think we need to see when a child experiences difficulties and they start to not feel well or become distressed. They become sad, worried, stressed and distressed. It doesn't mean that they are going to become depressed, have an anxiety disorder, post-traumatic stress disorder. Those are the big words for when they become ill. And by the way, in terms of prevalence, we also don't have recent epidemiological studies. It is coming through an international partner, but the SASH study, which is the same one, was citing the prevalence at 17 to 20% of children have a diagnosable mental disorder. And that was the study that was between 2006 and 2008 or 9. Is that worse? Now, probably. We do have a colleague who has published recently where they did some work in schools, and they are showing that up to 36% of children are presenting with symptoms of depression. Now, that doesn't mean that they may be depressed or have a disorder, but we should at least recognize that there are that many distressed children in our system. So, next slide, please. From a public health perspective, what do we need to do? And we all know this, that if we do not address early adversity or any adversity as it happens on the continuum, and we continue to not have the mechanism for children in distress or with disorders to be detective and to get intervention early, and if our services are not coordinated to facilitate that, there will be an increased burden of disease both in adulthood, right, but also in childhood. And this is exactly what we have been addressing and will continue to address over time. Next slide, please. So in terms of we call ourselves the ICAMS Strengthening Team, Infant, Child and Adolescent Mental Health Strengthening Team. We did think about how do we in the interim support the primary system from an operational point of view. So we recognized at the time that there was a low uptake of services to children at primary-based level, and we wanted to prevent this consequence of late detection. And so what we have proposed is the establishment of district-based child mental health teams. And what we have done so far is that we've established one of these teams that function across the metro. And already, despite the fact that we are only 2 years in, just having dedicated time to our primary colleagues, we have, for example, reversed waiting lists for admissions for children from 25 on a weekly waiting list last year to most recently 2 to 3. And so we have been able to actively intervene, and that would include actually visiting our district hospitals, supporting our colleagues where they work and where the child is. If the child needed rapid admission, we would facilitate that admission. So as a model, it has been extremely effective. Next slide, please. In terms of our communications and systems alignment, I'm extremely grateful for having been included in the Provincial Mental Health strategy and project, and so have worked with the colleagues and with our HOD to ensure that the stakeholders are engaged and to ensure alignment to achieve this common purpose. For the first time, we are working much more closely with colleagues within the different sectors. A lot of work to do, but with the right intent, I believe that we will achieve what we would like to. In terms of our roadmap, our tertiary mental health services will need to become more integrated and involved with the ecosystem. Our big focus at the moment is to strengthen the front line, as I said, and it's not just to provide training to medical officers, that's what MO stands for, sorry for the abbreviation, but also to our registered counsellors, our nurses and other frontline workers, and our digital project. And then there has been a lot of work with our sectors. We are working more closely with non-profit organizations, for example, and we've made partnerships even with an international partner who's really assisting us to actually get this new model embedded. But you may ask, what about the parents? And that is extremely, extremely important if we really want to address adverse childhood experiences. And one of the ways, of course, next slide please, one of the ways, of course, is that we get our early years project working. So we will work at the level of preconception, in the antenatal clinics, at the birthing sites, but the other is to design effective parenting interventions. And one of the interventions I want to mention that, and a team that we've been working with, is a parenting intervention called SWIFT, which stands for Supporting Wellbeing Through Integrated Family Training, and they're using a digital platform in order to provide this training. And we're working alongside them as one of our partners to actually strengthen our parenting initiatives. And I'm sure there are many others because we recognize the importance of supporting parents. So, to conclude, 3 take-home messages related to children and adolescents. The first is the lifespan approach is going to be key. Early intervention in a collaborative and integrated manner is vital. We have a big and complex system, and we have to shift our ways of working in order to take on all of the challenges that we face. And most importantly, that we have a coordinated and collaborative approach to address and prevent adverse childhood experiences. And if we do that, we will see a decline in suicidal behavior and deaths by suicide. I have no doubt about it. And so the take-home message is, I'm not sure if you're going to take over here, Carol, if that is okay. I think we can all agree that mental health is everybody's business and that there can be no health without mental health. The World Health Organization indicates that mental health will be the biggest crisis we will face by 2030. Unfortunately, our province has the highest documented lifetime prevalence of common mental disorders, and when we speak about common mental disorders, we're talking about depression and anxiety. And it is important to note that our department is committed to ensuring that we provide quality mental health services within the available resources. We acknowledge that mental health was previously siloed. It created fragmentation and unfortunately stigmatization, and we are increasingly working to integrate services within the department and across departments and work with our partners. The challenge that is recognized is being addressed so that we can work effectively in the intersectoral space to manage this increased burden, and that the whole of government and whole of society involvement is critical. I thank you once again.
Thank you, Dr. Nessa, and thank you, Ms. Dean. Colleagues, before I give over to questions and answers and comments, let me acknowledge the other members who have joined us. I see them online. Members, you are welcome. Colleagues, any questions? I notice Member Walters.
Okay, let me first say that something that really resonates with me is the whole of society approach, the lifespan approach. I think right up front, when you explained it that way, everything else made sense to me. And it would be useful for the committee to perhaps, I'm trying to find the right way to describe it, but to have an ideal pathway for somebody. That's a child getting born, and what the ideal life path should be and what people should be experiencing, what support they should be getting, because I think it would help a government to also understand its own interventions and partnerships it needs to form towards a whole of society approach. And then my second observation is, and this, I'm sorry if I'm going to go in a bit of a meandering historical path here, but I think part of the challenges modern society face is we come out of a history, I always say it's 19th century bureaucracy in structure and thinking, segmenting society, organizing society in a manner that the state can better administer it. And you have extreme version. I think apartheid, of course, was extremely harmful version of that. But it's fundamental in a state that it tends to work in segments. It tends to have competition between different departments for budget because of those segments. It has its own logic and rhythm. And then today, of course, we have 21st technology, but we still have that state structure and all the underlying assumptions and cultural assumptions that we have in terms of how the state should operate. So what I'm hearing here is potentially very transformative in the sense that it reconceptualizes the role of the state in society. And I think that's what I read here. I don't know whether I'm taking it too far, but it would be, but in order to realign and for a government to better adjust itself and change, it would be useful to actually have a picture of here's a child being born, what should be happening until cradle to grave, what should be happening, what should they be experiencing. In fact, I find it fascinating, and I won't bore you with all my very specific questions. Hopefully we'll get a chance over a coffee, but just on the slide, you referred to it as a very busy slide. There was something that I didn't immediately grasp, the difference between warmth and control. I've also find it an interesting one because it moves out, nearly moves from the more systemic, typical thing politicians engage with, and that occupies our minds, to the more immediate, call it drivers of human behavior. And I'm also, so if you can just explain, that's my one question, warmth and control, if you can maybe just help me understand that better. And if I can just add to the suggestion that I'm making, if we get it right as a society, and if we get it right as a government, then I do believe it is, I think fundamentally, to go to the old dictum, any organization, if its people are functioning well, the organization functions well, the same for society. I think this is the difference between people being able to look at the environment, understand the environment, take opportunities, being self-aware, and people that are currently locked in many respects, and I don't think it's just a phenomenon of poverty. I suspect it's a phenomenon also of highly competitive, or superficially successful people. But it's the difference between self-aware, critical citizens able to empower themselves, and citizens, the difference between citizens and subjects, if you know what I'm saying. So that, I know it's quite a lot of thoughts here. I really find this interesting. But yeah, two comments: the pathway, if that could be conceptual as a suggestion, and then the question of warmth and control, please. Thanks.
Shall I start then with the lifespan approach?
Sorry, Dr. Nessa, do you want to take a question and respond, or would you like to take maybe 3 questions and then?
I think it may be less overwhelming to respond per question.
All right, before you,
all right,
no, that's fine, Doctor. Before you respond, for the record, the members who have joined us online is Member Jacobs and Member Bryant. And Member Bryant, I see your hand. We will give to you when Dr. Nessa's responded to Member Walters. Over to you, Doctor.
Thank you for the question. So just on the lifespan approach, it's not a direct answer to your question, except to say the economic argument has been made over and over and over. And I thought that we're not going to clutter the slides with too much detail. But for example, a couple of years ago, there was a Nobel Prize winner for economics who made the argument about it just makes economic sense to intervene early, right? And in fact, yesterday, one of our international partner colleagues who met with myself and my colleague, she sent me an article about the most recent kind of literature that I could look at. And we had a conversation with him to say, so what did you do in the UK, for example? I know we're not the UK. We don't have the envelope of money. But what was the argument for the lever to be turned to prioritize mental health? And she said we made a convincing economic argument. Now, the thing about the economic argument is it's cheaper to intervene early. It's very expensive when you get to, along the life course. So to get to the more direct answer, we have thought about it, and as we speak, I'm going back to one of the slides where there's been a lot of thinking about the life course approach. And what we're going to be doing within the ICAMS team, we are going to take these nodal moments like pregnancy, infancy, childhood, adolescence, and then we will partner with our colleagues on the adult side, and we're going to do exactly what you suggest, because we need to look at what is the ideal along this continuum, where are the risks, and what exactly do we do. Now, it's easy to say what we have to do, it's the how. How are we going to do it? And the partnering is going to be very important, because this cannot be something that health is going to get right on its own. And we're going to have a very sophisticated graphic, and then there will have to be agreements, because we're going to have to say, this is what we have to do, what is going to be your role, what's our role, and what are going to be the indicators so that we can actually measure whether we are on the right path. Does that answer the first question? When it comes to warmth and control, we're speaking about parenting styles. We have shown that permissive parenting where there is a lot of control, actually results in adverse behavior, whereas warm but authoritative parents actually protects the child. So that's the little graphic there. Do I need to say more, or is that okay?
I think we should explore it in more detail. I also don't want to bog down the committee with what I find interesting. But yeah, it answers the question. Thanks.
I'm going to give over to Member Bryant, and then after Member Bryant, it will be Member Van Vogel.
Thank you very much, Chairperson, and it's good to join your committee for today, filling in for Member Van Minnen. It's just a very quick and relatively simple question. A lot of the information that's being provided is quite ambitious and I think justifiably so. But I think the question at the moment, especially facing the Western Cape in terms of finances and budget, do you find that you have to temper some of these more ambitious projects and ways of going forward with the challenges that one is currently facing from a budgetary perspective, and how so do you then plan for that going forward? Thank you.
Thank you for the question, if I may, sir.
Yes, you may.
Okay. Yeah, it has been challenging, and we cannot deny that. I think the good thing about the additional funding we received for the 2 years, as I call the new funding, the 80 million, that's been protected. So there was a period that we couldn't fill posts late last year because of austerity measures, but we still have the money for those posts. And those are to strengthen primary health care with additional resources like registered counsellors, some nurses for mental health, social workers, OTs. Dr. Nassen's Strengthening Fund for Child and Adolescents, also protected funding, and we're very grateful for that. But I think as government, probably globally and nationally, we're all under pressure, but we've been very clear in the project that we've spoken about. We are clear about gathering as government departments, the ones we mentioned particularly, and to do sense making of our various roles. And you were asking sir about the mapping. I think that's what we've learnt in our pilot projects, that when we work together, we cut out duplication and we're a lot more focused. Just one thing I want to share as a department, we've also adopted a policy of the ecosystem and authorizing framework where we're starting to talk about what happens in a geographic space. And we haven't determined the boundaries as yet, but what happens in a particular space? Who are the stakeholders? How do we work differently from the bureaucracy to a more matrix engaging approach around the focus? Lots and lots of exciting work, but lots of work to do, but the trajectory, I think, has been carved out. Thank you.
Thank you, Ms. Dean. Do you want to follow up because it's Member Van Vogel? It's a new one, I'll come back to you, Member Van Vogel.
Thank you, Chairperson. Chair, let me first welcome the presentation of the department. And I agree 100% that mental health is indeed everybody's business. When you visit healthcare facilities in poor working class communities where substance abuse is it's a problem of it's high, then you realize that that we have a problem we are going to have a problem when it comes to our leaders of tomorrow, with our doctors, with our teachers. We are a broken community actually. But what I also want to know, and I'm happy to hear you speak about a whole of society approach. But what I would like to hear from the department is what collaboration programs is in running in partnership with the Department of Social Development and Cultural Affairs, Sports. You mentioned something about education. And then also secondly, what progress has been made to address referral challenges. I visited once and I've done, we as the Standing Committee done an oversight visit at KGH hospital. And there was, I think, no, it was more than 2 rooms. People were sleeping on the floors and it was bad. And it's young people. So in terms of that, and I know that Kailija, it's not a funded program of responsibility that they are taking up on themselves. It's not funded. They are using their money to support that type of work. So from your side, what progress has been made to address the referral challenge? Because I know there was a referral challenge. To address the referral challenge from Khayelitsha and surroundings, surrounds even to Lentegeur Hospital. Then lastly, Chair, I think on slide 11, or let me first, I just want to understand from you, what do you think, why is there this high, I was just wondering, the high, why is the suicide so high between the age group of 30 and 34? You are the experts, if I can get that understanding. And then lastly, the lifetime prevalence in adults with regards to this high prevalence of mental health amongst adults. I would like to understand how often does it lead to suicide attempts, and how many cases of incidents from mental health challenges do you receive on a, let's say, a monthly basis? Thank you, Chairperson.
Thank you. Over to you, ladies.
Okay, so we'll share a response to you, Honourable Member. So I wasn't with you on the visit, but I'm fully aware of the Khayelitsha, and I don't manage Khayelitsha, but they do refer to Lentegeur Hospital, which I oversee, and we've known about the challenges. I think I said earlier, mental health has started on a low base funding-wise. And 20 years ago, when we introduced mental health services, and I'm saying mental health, but it's really for those who are mentally ill, into our district hospitals, there wasn't additional funding. The infrastructure wasn't set up. And so Khayelitsha has needed to deal with all those issues. They are busy building a new unit, which is great news. But as we know, staffing is always an issue. But I think things have moved on. I think when the standing committee did the visit, there was no dedicated psychiatrist. It's been difficult to hold a psychiatrist in the space. In the last while, we had a psychiatrist who was there for 2 months, I think, and then she resigned, and a new one started the 1st of September. So we're feeling a lot more hopeful because that really helps. And we are far more active in the integration and continuity of services between ourselves as Lentegeur and Khayelitsha and just holding hands. The issue is our demand outstrips our resources for acute psychiatry. And when we spoke about the 39%, we were talking about common mental disorders. And when we talk about psychosis, we're talking about a more serious mental disorder. And we're talking about the most serious of serious is what we see coming into our services, because someone is really so ill that the family can't hold on to him at home or her at home any longer. And we have no control around those numbers. And that's why I wanted you to pay attention to the substance-induced psychosis, because if we took that out of the system, so to speak, our system would be a lot more easier. It's not that simple, right? So we are seeing growing numbers for that in that area. And of course, our match of resources and appropriate infrastructure is the result of what you're seeing. We're trying to play catch up. And hopefully in the next year, when you visit Khayelitsha, it will be a different experience. We're also trying to strengthen referral from hospital, be it Khayelitsha and Lentegeur, into primary health care by capacitating them more to deal with people to prevent relapse. So it's quite complex. There's also transitional care we're looking at, but it's all systems and funding that we don't necessarily have. And now we're getting this 80 million and we're trying to do that, and we're trying to work out the relationships. So the relationships, even just within the health department, we are working on constantly. In fact, we're talking about collaborative spaces so we can deal with issues like this and take joint responsibility in an ecosystem, in addition to inviting DCAS and social development and education, etc. But it's all step by step, and it's slow work, but effective work, and it's been ongoing. So I probably have a better report when we come in the next 6 months or so. So I think for me, Khayelitsha, of course, under stress and will continue to be under stress, but there have been some changes, if I may speak on their behalf, and just our relationship. And the collaborative space is definitely starting to connect and knit a lot more. Our department is very clear about where we're going, but it's now the HODs to HODs, and we work very well at a local level, and we're trying to knit that and have that mandate that I would like going forward. So thank you. I'm going to hand over the suicide discussion to Dr. Nasser.
Yeah, maybe also just to mention something to do with collaborative partnerships. So we're working quite closely with the Western Cape Education Department, with a colleague in the special education sector, for supporting children through provision of training around emotion regulation. To access a child is not to wait till they arrive at the clinic. Many of them don't want to come to a clinic. And so we really need to support the psychological care and services for children within schools. So that's the one project that we're doing as a partnership, but also working closely with very impressive data that they've collected since 2022 to now about self-harm and suicidal behavior, and to look at a collective approach to how to address and, of course, to prevent it. What we also need to do is to partner more effectively with the Department of Social Development around child protection and how do we intervene for the distressed child. Whose job is that to do? It's all of our jobs, but we need a strategy, which I don't believe we are effective in yet, to really address this phenomenon. At the moment, again, the need in terms of children requiring care and protection is exceeding the resources. And so it is a crisis. We can help in terms of providing support and training to manage adverse behaviors of children who are already in care. But that is still a work in progress, I would say. But we do have good collegial relationships with our colleagues in the Department of Social Development, as well as culture and sport. Your question, why is suicide so high in the adult population? So I'm going to take you back to children first, right? And then I don't dare to speak for the adults because it's not my professional domain. But I think the easiest way to look at this is, and this has been shown in research, by far the majority of children who die by suicide or make a suicide attempt do not have a mental illness. And the younger they are, the less likely it is that they have a mental illness. As they get older, when you get to the 14 to 18-year-old, then possibly there is depression, there's severe anxiety, there's what we call trauma-related conditions that result in such overwhelming distress that they resort to suicidal behavior. Right. Now when we come to the older group and we're thinking of that continuum, the older patient has a greater likelihood of a depression, but there are two factors, the presence of a mental illness and the presence of severe adverse situations, which the person feels that there is no way out of. And that, coupled with substances and all of the other social ills, are placing these adults at risk of completing a suicide. And that's not a modern term anymore. We say death by suicide, but I think that would be a useful way of seeing it. I'm looking at the numbers here, and I see 30 to 34 years was the highest number. And there are whole lots of other risk factors for suicide among adults, for example, a family history of suicide, having lost somebody by suicide in the family, and so forth. And the means. So when you're an adult and there is the means to harm yourself, the presence of guns and so forth, that's when it results in a death. That's a very limited answer by a child psychiatrist speaking about adults, so forgive me.
Member Walters?
Yeah, Member Windvogel touched on it as well. I think it was a very important input, and I would like to expand on that. It would be interesting, I don't know whether it's possible, but I do think it will be enormously useful for us as legislature members to be able to, maybe I should stop and give myself a bit of background. I'm the chair of the Police Oversight Committee as well, which there's a very similar principle, not that I want to confuse what you are saying with that, but there's a similar principle. You don't want the conditions of crime to exist in the first place. You don't want to deal with the end result of a problem. You want to get it early, and it makes economic sense. It makes sense it's just the way to go. But it would be very interesting if your data, cultural and sport education, if you can actually compare data. I'm not sure that is seamlessly happening. The thinking is there, but it would be, again, for us to play a good role, for example, in our oversight, to know which areas are problematic from a mental health point of view, unemployment point of view, schooling point of view, it does help us to profile where we should do oversight. And I incidentally raise it in every committee that I'm part of. I think I certainly don't want to be in a position where you thumb suck your oversight. You want to know what questions you ask. So what I take, for example, out of this presentation is just going to take a couple of ones. Substance abuse. Where does it take place? Social circumstances you touched on. You mentioned earlier you're not in a position yet to geographically isolate it, which I think is going to be very important. And Chair, this would also be a suggestion for the committee, is that we look at integrated data between different departments within different committees, because I really think it's going to be important to help shape a reconceptualization of what government does and how it interacts with society. Thanks.
Member Van Vogel, follow up, and then Member Hendricks.
Thank you for the question.
I will take the scope, Chair. I'm sitting in my area with a patient who are waiting for a bed for more than a year now. And I know adult psychiatric admissions. I want to understand what is the number of beds and staff per psychiatric hospital. Are there any challenges? Because the picture that you are painting is like, and you guys are okay. There's some few, but you guys are okay. And what, if you can give us some details, because I'm from a rural area. Ek is 'n plaasgirl. So ek is van 'n plaas area of a rural area, not plaas area, but 'n landelike gebied. And it's so difficult for us in the rural areas to get access to this type of services. So, and normally the answer get is like, and there's no beds, space. That's why I'm still sitting with that patient. It's in, it's out, and it's... But nevertheless, then lastly, Chair, I want to understand if you are going to mention the issues of problems, what are our government of what is government doing about it? Is there any interventions? If you are going through things of, if there is problems of shortages in there, what programs to address these challenges? What programs are there to address these challenges? And also, which hospitals are mainly affected by these shortages? Thank you so much, Chair.
Thank you. Over to you, ladies. Member Stevens.
Member Van Vogel also touches what I actually wanted to ask, but the suicide rate in the youth is risen by 15% over the past 3 years, highlighting the urgent need for effective mental health interventions targeting this demographic. So I want to know, how will the Western Cape government ensure that mental health services are equitably distributed across urban and rural areas? And what strategies are in place to reduce waiting times for child and adolescent mental health services? Because I myself, my brother lost his son-in-law, 25 years old, 2 months ago due to suicide. And in my community, a lot of children, for last year, 2023, and even in this year, committed suicide, a lot of youngsters. So I don't know how accurate are the figures on yours, or the Cape, the metro is the highest. But only in Kryfton alone, I know about more than 10 suicides between late 2023 and 2024, of which a young girl at the high school, Scottsville High, hanged herself in the sick room. She asked the teacher, she's not feeling well, if they can give her a tablet. She wanted to go rest a while. So the school gave her the tablet, and she went to the sick room to go lay down. Nobody checked on their child. 2 hours after the school closed, the mother went to go look for the child. She never came home and then realized that she was in the sick room and they found her hanging in that sick room. So that's why I'm saying we really need the department to do something and actually speak to the schools as well, because a lot of suicides are happening at schools at the moment, and to me it seems like nobody's really doing something about it. So they actually need to be more interactive with the schools itself to say that they must be on the lookout for the children, see the children's moods, because I spoke to a mummy last night that her granddaughter is also suicidal because the child gets bullying at the school where she is at the moment in Bernardino Heights. But she doesn't get bullied by the children on the school. It's by the gangsterism, because the school is in a gangster area, yes. And okay, they put her on a taxi now, but the child is so afraid to go to school that she didn't went to school a whole week now, because she's too afraid, because the taxi is also stopping outside the gate, and she must get from inside to outside the gate. And even there, I spoke to the police officers, but with the shortage of police, they can't guarantee that there will be police visibility at the schools at all time when the schools come out at 2 or 3 o'clock. So that's also an issue at the moment. So we don't even know what to answer to that grandmother, because she's now also very stressed out because of her granddaughter, and the child is only 14 years old. So at the end of the day, there's no help, and the children committed suicide. Thank you.
If I can answer the last question and start with that. So as I mentioned, on Tuesday, in fact Monday, I'm sorry, for the first time, I was in the building of the Western Cape Education Department. And I think it's a powerful indicator of intent that we're going to work together. I met with Mr. Ewald Krause, and he is leading the collation of data, right, so that we can understand where the hotspots are, to answer your question. So they are doing quintile by quintile, they are using absenteeism, they are using food insecurity, they are even profiling schools that are more vulnerable, so that we can get to a point of identifying an at-risk child so that we can intervene before a child is found hanging. But having said that, what I requested was to please, for the Education Department to share the suicide data with me so that we could understand in a more granular way what have been the particular circumstances that have led to a death or to suicidal behavior, because it's all of these factors that you are talking about. And so we are committed to working alongside our colleagues. But what we have been told, and one of the questions I asked Mr. Krause is, explain to us how your system works. It's very similar in a way to health. It's a government department. There are different roles, different functions. And he explained to me that in terms of any crisis, be it suicide or anything, there is the Safe Schools project where there are helplines. But when it comes to suicide, then the first responder is the school psychologists within the Western Cape Education Department. They get called out and intervene. But there are lots of challenges that we have to work together to try to unpack. One of the challenges is everybody panics. And the interpretation of what is actually happening in the moment is not always as sophisticated as it needs to be, right? And there's an acknowledgement of that. And an acknowledgement that we dare not anymore allow children to fall between the cracks. But unfortunately, I can't say that we are there yet. I've received the information. We are going to work together. We've already created a data sheet so that we can understand and we can get to the point where we know exactly where the hotspots are geographically. But this is also work that has been done for the adults. For example, we have a colleague at the MRC, the Medical Research Council, who literally has been able to show where these hotspot suicide events happen. The issue really is the speed of intervention and what intervention needs to be provided within a space of time. So this is the journey we are on. And unfortunately, it is a very distressing thing where, we want all of the problems to go away as quickly as it can be. If I can go to Honourable Walter's question about the data and what is happening on that front, just to expand a little bit more. The Provincial Data Centre has really collated a lot of data for us, and my colleague can expand on that. But then we also have hectares, as I mentioned. There's data where we can actually track trauma, suicide, stuff like that, and we can actually see which hospitals, so we are able to actually say where the hotspot is. The hotspot area is where I work, Kailicha, Eastern, Subcontained Visual Plain. That's the hotspot. We know it. How we are going to intervene to manage the numbers, that's the reality. The demand is outstripping an active and timeous response. And so those are the things that is happening on the provincial front, and maybe Carol, you can expand on that. My area is to work with education and to see what we can do around the suicides. I'm back to you, madam. We're also doing lots of training. We partner with our colleagues. So in West Metro, we have a psychologist dedicated to child mental health who partners with us in our ICANS team to deliver suicide workshops. And we've done it before, we'll do it again, and we are trying to capacitate our colleagues to be responsive and not frightened by this. There's a lot of anxiety around it, and we have to do better to intervene earlier. Hopefully that answers your question.
Thank you. There are so many factors to it because we often see cases after the events. So I'm very sorry about your personal loss. It has been a difficult area, but it's been an area that I think people have chosen to come together around because we all feel so helpless in many ways. And yet when we put our resources together, we're so much stronger. Just about the data, I think you were asking about how do we integrate it. So the mental health steercom, we have representation from the departments, including Department of the Premier and our data center, as Dr. Nassan was just saying. And there is some work that they've been asked to do to look at the local data and then make sense of it. I also spoke about our ecosystem approach. So that's part of the thinking around the model. In addition to that, known perhaps to this committee, is that we have something called the area-based teams approach, where we have the violence prevention unit directorate in our departments. So part of the work that they're doing, I'm not that qualified to speak about it, but part of what they're doing is to look at the data and look at the hotspots, because they also have SAPs on their committee and law enforcement on their committee. But now we're trying to bring all of that together under one branch, so to speak. So on Tuesday, we're having a meeting via the mental health steercom, and we're going to a more local space to talk about these interventions. So all the departments will be represented there. The chair will be Dr. Kluti. We're going to our director in the substructure. And for instance, we're going to say, if we're going to intervene with child and adolescents in Delft, as an example, how are we going to do that? If we go to Hanover Park, what does it look like? And who are we? And what do we bring to the table? So slow, but exciting. And I think it is become extremely focused in the last while. We've done all the preparatory work to get to this point. So I think we'll have a lot more to share in the coming months. You want to just respond?
Follow up,
And then
Dr.
I'll
Leslie.
just respond to the bed over here.
I wanted to respond to you about, you painted a picture about the rural areas and the difficulty around accessing service. You know, we've had referral pathways for years, but it's not very visible, because in the past we were sharing our pathways through emails, and then people leave the service and nobody knows what the pathway to care is. And this is why we have dedicated ourselves to a link to the website so that this information can be visible. And that is going to help, at least within any area, to know where is the first step to be able to achieve a service. However, it doesn't end there. We do have colleagues within the Provincial Health Department who look at innovative ways to deliver and respond. And one of it is about designing a telemental health project and intervention so that our rural colleagues and partners can access, for example, specialist care. And so there are those kinds of discussions and plans in place, and hopefully we'll be able to see that rolled out in a more effective way. Because the way that the services are structured, as you know, we've got specialists up here, and then we've got a base of generically trained healthcare workers who need a lot of support. Do you want to add anything?
Thank you for that, Dr. Nassan. Yeah, I mean, I don't know the details of waiting for a year, but there are some cases where people wait very long for a bed. We've tried to deal with that. Case by case sometimes, like child and adolescents at long waiting lists, psychogeriatrics. We invested some money from this special money, new money, into those areas, and it's made a difference. Hasn't taken the problem away. So it'll be interesting. Maybe you can write to us and just share the information on that. But in terms of beds at a psychiatric hospital, we've got lots of beds. But for acute psychiatry, we've got just under 650. It sounds like a lot, but we've got all the hospitals draining through some way to those few beds. And it's spread over Stikland, Lenteheer, and Valkenburg. So how it works from a rural area, there are 3 regional hospitals, Paul, George, and Worcester. So smaller hospitals refer to those regional hospitals, and they refer up to us. So yeah, it is tricky and it is difficult, but we try and manage that as much as we can. And as Dr. Nassan was saying, that telemental health has become something that we must seriously partake in. And it's going to be new and different, but there just isn't enough people or beds to do business the way we did it a couple of years ago. I hope that answers the question too.
Yeah, I can just add to that. Child and adolescent beds, fewer than 50 beds. But as I mentioned earlier, we actually seen a decline. We are not seeing long waiting times. The impact of our outreach team has been significant. I don't know if General Adult Services can do the same strategy and way of working, where we've literally gone and we've assisted and helped, and we actually provide weekly telemental, so it's online outreach and support to our colleagues. They discuss the cases, they prioritize, we take who needs to come, and others we go. And we've really seen a reversal to the extent, if you recall, that we were given 8 million. The significant chunk of that 8 million was going to be to increase the number of adolescent beds. That was the plan and intention. We don't believe that we need those beds anymore. Now, that's not to say that the need has gone away. I think it's just to demonstrate the effectiveness of being able to intervene in a responsive way. Adult psychiatry has numbers that our numbers are relatively few, so we can approach it in a different way. But in terms of the trend downwards, we will be able to share those kinds of numbers, if that will be interesting, to actually see the trend of, because we keep weekly waiting lists. We also provide all kinds of daily kind of interactions via regular communications via WhatsApp. So the colleagues really go out of their way to respond and to try to facilitate care and to ensure that we risk strategize to the best of our ability.
Members, I think it's my turn now in the absence of no further questions and comments. Folks, you'll have no idea, my mind was going all over the show. I'm right in the middle of all of this. I'm a divorcee, and I have twins, and one is getting treatment for ADHD. Was it attention deficiency hyper disorder? And his sister is the total opposite. She's away, she's ahead in terms of her age academically. He's behind. So much so that there's a decision been made that they must be separated in class because she would come over and do his homework for him. And he's got that mentality even at home and even in class. He calls his sister in front of the teacher, can you come here and resolve this? Now, and on one of the, also, my current wife has been at one stage also diagnosed with depression. So I'm dealing with everything that you've just now highlighted, what life is all about. But then the other thing is that on this slide, you also have cartoons, you know, and the boy, that's all he wants to do. And he sits with the gadgets. That's all he wants to do. And his sister, she would look at academic things, cooking, baking, you name it, you name it. Now, why are you having cartoons on here? And what is the purpose? And what is the purpose of that? And then also, I can't make the link with substance abuse and all of these disorders, whether the one leads you to the other or is it vice versa. For instance, as an example, at university and at college, we started drinking for fun. Now, is it that fun drinking that has taken us to depression and stress, or is it stress that took, unknowingly, that took us to drinking or whatever, etc.? And then also on the question asked by Member Van Vogel in terms of the waiting period for beds. On a housing waiting list, we have the same problems where people say that they've been waiting for years for the housing opportunities to get to them. And what we found is that some people fall off the list. They, for administrative negligence or whatever. So I'm just thinking out loud, is that also not maybe something that one should zoom on, that a patient administratively just disappeared from the list with the adding and the subtractions, etc.? But in a nutshell, I think I'm going to become friends with you because I don't know how to deal with some of the issues that I'm currently involved in. You know, I drive my wife crazy because, just for the record, and I know I'm wrong, you know, I would say to my wife when she gets into that mood swing, and she would say to me, it's my depression. Now, I would try and play reverse psychology, which I might be totally wrong. I would say to her, you are diagnosing yourself at this moment, saying to me, you're doing this because of depression. Now I'm saying to her, why don't you reverse it for the solution of it? Say to that depression, I'm not going to drink water and it's going to stop, you know, because she would say that is the lack of water that makes me do this. Now I would say, why don't you drink water? I don't know, I might be totally wrong. Over to you, ladies.
Thank you for your comment and question. Let's start with the cartoon. So I'm very fortunate in that I lead a team of ages. The oldest member of the ICAMS team, I think, is about to turn 70. I had to approach retired people who are very productive to put up their hands to come and help, because it's very difficult to get colleagues who are already busy with providing clinical services to come and be part of a team. But the youngest is young, and that's the cartoon that the young one put there, and she is leading the digital project. Of course, it would be a young one. And I can't recall what she called us, but she thinks that we are kind of super ninjas. And she likes the way of portraying us, that we're kind of making magic and we're doing. So that's the cartoon, sir. It's how we would like to identify ourselves as a team. When it comes to your son and daughter, yes, ADHD is in my ballpark. It's not all doom and gloom. When it comes to children presenting with mental disorders, we see it more commonly in boys than girls, at least before they become teenagers. And let's be careful not to say the wrong thing here, but it may be that it's got to do with resilience. The question is, are girls more resilient than boys? Possibly so. Until they become teenagers, and then they start to struggle with depression and anxiety. And so, yes, you're going to see this difference. There's a lot of understanding of ADHD, how to treat it, what the risks are. There are effective treatments, but it's not just a medication. It's about managing behavior. It's about recognizing that it's very distressing for a child not to be able to keep still, not able to focus, and they get kind of isolated and bullied more easily. So they need a lot of support. They need a lot of focused attention in the classroom and in the home, so that we can do what I told you in the first slide about how do we look at this in terms of the risks and the protective factors. Now, we know the risks of ADHD. If the child doesn't get support, there's a risk when they become teenagers of an increased risk of risk-taking behaviors. Substances, driving in cars, thinking before, acting before they think, very impulsive and so forth, and unfortunately a risk of other disorders, oppositionality, behavior problems, and depression even, right? So that's the severe end. But that's not the case with most kids with ADHD, right? Most of them can do quite well with support, and the support needs to come from within the home. And so there is a lot of literature about the impact of parental mental illness. The parenting styles, we're talking again about warmth and control and permissiveness, all of those factors apply when trying to facilitate the best outcome for a child's development. The last thing to say positively is that a big percentage of children with ADHD do outgrow it. But of course, with the right amount of care and all of that.
That's very encouraging for me, but I'm still going to be your friends. I think, do you want to add on?
There was just something about substances. I wasn't. So there is a link between substance abuse and mental illness. Unfortunately, we call it a dual diagnosis, to use more medical or clinical terms. And that is a factor which is driving our high rates of admissions. So if I just again use the example of my more familiar territory, at Lenteghe Hospital, we have 2 adolescent units, and by far the majority of the kids have used some or other substance, and many of them have become psychotic as a result of using substances. And the pattern is clear. These are children, some of them have ADHD, some of them have learning difficulties, they drop out of school or they can't be managed in the school. They land up on the street corners, somebody offers them a substance, and it takes about a year or two of use of cannabis and methamphetamine for them to become psychotic. And repeated use results, unfortunately, in the more severe end, which is schizophrenia and mood disorders like bipolar mood disorder. Right. So there is a link, unfortunately, particularly in those where there is a family history of mental illness, or what we call a genetic loading for mental illness. So these social ills are the drivers of these big numbers. And so how are we going to turn off the tap? Are we going to provide more and more beds? Or are we going to recognize that we need a focused intervention to prevent substances, both in adults but also among young people? And unfortunately, they are becoming younger and younger, and we have intoxicated children of 11, 12, 10, who are behaviorally disturbed. People think they're mentally ill, but they're not mentally ill. They are intoxicated, unfortunately.
Christine here.
So thank you for all this very fascinating questions. So as a department, we have a role to play when it comes to substances. Detoxification, screening, and social development's got a role to play. And we are finding our way again. We've always worked closely together, and we had COVID and all the rest of it, but we're coming together again to see how we can close some of those gaps. But substances goes beyond mental illness. It's impacting other services as well. Maternity, for instance. In our trauma, we're seeing such high numbers of substances. So I think we all recognize the importance. In fact, 2 weeks ago, we had a presentation on substances, and maybe as a follow-up meeting, we can combine it with our mental health inputs and perhaps invite our sister department as well. Thank you.
Ladies, thank you very much for the insightful presentation. Colleagues, I'm going to call for a break, and we can be back at 11 so that we can wrap up our work. And ladies, you're more than welcome to join us. I still need to talk to you over coffee. I know Member Walters made a suggestion that maybe over coffee we should also make time to engage. Shall we adjourn for a break for the smokers, and then we come back again? Thank you. Colleagues, thank you. We are back in session. We are now going to go to point number 9, and that is the considerations for the adoption of minutes of the 16th of August, looking at recommendations, but I think we'll start with the recommendations. PO, any of the recommendations that stands out?
No, Chair, not really. I don't know whether this is a recommendation. Member Walters, I don't know whether you want this to be a recommendation.
Yes.
He said that it will be useful if the Department of Health and Education can compare data to identify areas problematic for mental health for oversight purposes. Look at the integrated data between different departments within different committees to help shape reconceptualization and what government does and how it interacts with society. So I'm not sure whether...
Chair, obviously it will need to be unpacked in the future, but it's an accurate reflection of what I suggested. Thanks.
Okay. But Chair, I'm not going to send it to the department. Is it what needs to happen, or must I communicate this to the department?
Please communicate, because I support Member Walters in that, because even now at our discussion there, they feel the same, that, you know, social development, you know, what are they picking up? At the Department of Education, what are they picking up? Because some of these things happen at school, then it plays out in the family, etc. I don't know how you will deal with that, but they do believe that the data should be collated.
Okay.
And probably also, but that is what they will do when we give them another round for engagement. They will bring some more people who deals with other stats, etc. I don't know how to put that, but it's probably not a resolution, but it's something that they would know.
Do members need the detailed breakdown of beds allocation in psychiatric hospital, district hospital, regional and tertiary institutions, or that question was covered?
It was covered. So I think it is. It will come out as we continue to engage them in terms of whether there's progress or not. But I don't know, Member Van Vogel, it was your crucial point, the number of beds and waiting period. You know, so would you like that to be a resolution, or is it something that we will get as we engage with them on whether there's been improvements or not? Okay. So I think Member Walters, yours is the main resolution, and we will build on from there. I don't see any other hands online, so we will then go to the considerations of the minutes of the 16th of August and the minutes of the 23rd of August. Any proposals for that, for the adoption? Member Stevens is proposing and Member Van Vogel is seconding. Is that for both minutes? All right. The Monday you have it like that?
Yes, sir.
Or you want it individually?
No, it's fine. It's the members, because they already received the copies.
All right. Okay. For me, as long as it's on record, you know, so it's sufficient. All right, members, thank you very much, and the meeting is adjourned.
Thank you, Mr. Chair.
Thank you. Bye-bye. Enjoy the weekend.
Thank you, guys online. Thank you. Same to you.